Hi everyone, welcome back to your channel I Love Pharmacology. In this session, let us learn about the depolarizing blockers, which are the skeletal muscle relaxants. If you want to know the non-depolarizing blockers, please visit our channel and also the link will be given in the description. So coming to the overview, we'll talk in terms of the mechanism of action, clinical uses of the skeletal muscle relaxant, adverse effects of the skeletal muscle relaxants, and the summary as well as the bonus concept review. So the question to be answered at the end of this session is to which SMR will cause initial depolarization followed by the NM receptor, that is the nicotinic muscular receptor desensitization. So which is the mechanism for phase 1 block produced by depolarizing agent. You should be able to answer the mechanism for the phase 2 block by the depolarizing agent, and also why depolarizing blocker action is very rapid and short duration. And you need to answer which phase of depolarizing agent can be surmountable, and which drug augments the phase 1 depolarizing agent, and which SMR is responsible for malignant hyperthermia as a side effect, and which is the drug of choice for malignant hyperthermia, and why succinyl apnea occurs, and also the concept of Debicane number. So coming to the mechanism of action of depolarizing blockers, here the prototype drug will be your succinylcholine. Here one needs to remember that succinylcholine actions are similar to that of the acetylcholine. So in this diagram, whenever the action potential comes to the presynaptic or axonal nerve terminal, what happens? The calcium will enter, activation of the calcium channel will lead to entry of the calcium, and this will going to help in the fusion of the synaptic vesicles containing the acetylcholine, and this helps in the release of the vesicle containing acetylcholine into the synaptic nerve terminals. That is, the acetylcholine will be released into the synaptic cleft. Here, one needs to remember that, as we discussed, succinylcholine will act similar to that of the acetylcholine. That means succinylcholine will bind to the receptor to which acetylcholine was binding. So, which was the receptor to which the acetylcholine was binding? On the postsynaptic membrane. This is the postsynaptic membrane. So, it is the nicotinic muscular receptors. So, whenever you administer a succinylcholine, the maximum amount of the drug will be metabolized in the plasma itself by the plasma cholinesterase into succinylcholine monocholine as well as the choline, and remaining only few amount of or few concentration of succinylcholine will reach the synaptic cleft. And in the synaptic cleft, the succinylcholine will not be degraded or metabolized, because to succinylcholine to get metabolized, we require plasma cholinesterases, which is not present in the synaptic cleft. Only in the synaptic cleft we have a true cholinesterases which are able to metabolize only the acetylcholine but not the succinylcholine. So the succinylcholine concentration will increase in the synaptic cleft, and this succinylcholine will bind to the NM receptors on the postsynaptic membrane, and what will happen is they are going to stimulate the sodium channel. So the stimulation of sodium channel will lead to influx of the sodium, and simultaneously there will be efflux of the potassium. So, and this will cause depolarization of the postsynaptic membrane, leading to the generation of the action potential and impulse generation, which are responsible for the triggering of the muscle contraction. So if this process or the action continues repeatedly, what happens? So there will be activation of NM receptors, there will be persistent stimulation of the sodium channels that leads to persistent depolarization. These persistent depolarization will cause increased impulse generation, and this is responsible for the initial fasciculations. So once the persistent depolarization occurs, this persistent depolarization will lead to blockage of the sodium channel. So the persistent depolarization is responsible for the sodium channel blockade. So once the sodium channel is blocked, what will happen to the impulse generated, which is responsible for the contraction of the skeletal muscle? This impulse will not be generated and it will lead to flaccid paralysis. And this is called as the phase 1 block. The phase 1 block is mainly due to the persistent depolarization. So in the second step, what happens is, if there is excess concentration of succinylcholine, what happens is already there is a persistent activation of the NM receptor, this will lead to receptor desensitization, or it can cause receptor downregulation. So this will lead to action similar to that of the non-depolarizing blockers. That means in the phase 2 block, so it is called as phase 2, where succinylcholine will act similar to that of the non-depolarizing blockers. That means to say that succinylcholine will have NM blockade, NM receptor antagonistic activity. They block the NM receptor itself, leading to the phase 2 block. And this blockage of NM receptor, what happens? There won't be any opening of the sodium channels, there won't be any impulse, leading to the flaccid paralysis. Here the two things you need to understand is the succinylcholine mechanism can be learnt in two phases, the phase 1 block and phase 2 block. Phase 1 block is due to the persistent depolarization of the postsynaptic membrane, and the phase 2 block is mainly due to the blockade of the NM receptor due to the receptor desensitization or receptor downregulation. Here the two things you need to understand it, whenever you give a neostigmine which is anticholinesterase, neostigmine being anticholinesterase, they are going to increase the acetylcholine levels. So the acetylcholine levels will going to augment the phase 1 block, they will enhance the phase 1 block, they potentiate the phase 1 block. So if you give neostigmine during the phase 2 block, what happens? So neostigmine, if given during phase 2 block, it reverses the phase 2 block, it reverses the phase 2 block, it reverses the flaccid paralysis or relaxation. But whereas in case of phase 1 block, if you give a neostigmine, it will going to potentiate the paralysis or the skeletal muscle relaxation. So two things you need to keep in mind: whenever you give a neostigmine, phase 1 block will be enhanced or phase 1 block will be potentiated, whereas the phase 2 block will be reversed. Next, coming to the mechanism of action in terms of the flow chart, whenever you give a succinylcholine, which is acetylcholine analog, which will be mainly hydrolyzed by the pseudocholinesterases or the plasmacholinesterases. So pseudocholinesterases is also known as the plasmacholinesterases or butyrylcholine esterases, and it will not be degraded by the true cholinesterases which is present in the synaptic cleft. So this will lead to the persistent longer action due to the persistent staying of the succinylcholine at the synaptic cleft. So this will act similar to that of the excess of acetylcholine, and succinylcholine bind to the NM receptor which is present in the motor end plate, leading to opening up of the sodium channel, and sodium will going to influx into the postsynaptic membrane, leading to depolarization, which is responsible for transient muscle fasciculation. Following the depolarization of the muscle end plate, the succinylcholine which is remaining as well as acetylcholine which is released during the action potential, and this will bind to the NM receptor repeatedly, and there is a higher concentration of succinylcholine as well as the acetylcholine, and this will lead to depolarization. So depolarized membranes will remain depolarized. This is called as persistent depolarization, and no depolarization will occur, and there will be unresponsiveness to the additional impulses. This will lead to the flaccid paralysis, and there won't be any skeletal muscle contraction, leading to the phase 1 block. So before phase 1 block, you will encounter two things. One is the transient muscle fasciculation initially, followed by the flaccid paralysis due to the persistent depolarization. So, and this phase 1 block can be augmented or potentiated, but it is not reversed by neostigmine. So whenever you give a higher doses of succinylcholine or prolonged infusion, what will lead to is there is a dual blockade. So dual blockade means it undergoes the phase 1 block similar to that of the mechanism we have explained, and following that, if there is a continuous exposure of the NM receptor to the succinylcholine, this will cause the down regulation, or due to the persistent depolarization, the receptor get desensitized as well as down regulated, and this will prevent the sodium influx. Thereby it will decreases the impulse generation which is responsible for skeletal muscle contraction. So consequently, what will lead to is there will be relaxation of the skeletal muscle, leading to the phase 2 block. So phase 2 block is mainly due to the receptor NM receptor desensitization or NM receptor downregulation, and this phase 2 block will be reversed by the neostigmine. So coming to the succinylcholine pharmacodynamic actions, so mainly it is given through a single IV dose. There will be fasciculation which can be seen in the chest as well as the abdomen. There will be complete relaxation in the 1 to 2 minutes, and the action will going to disappear within 5 to 10 minutes because it will be degraded by the plasma cholinesterases, and only the small amount of drug will be there at the synaptic cleft. And there will be muscle soreness. So because of the potassium which is effluxed into the plasma, this will lead to the muscle soreness. So the fasciculation induces skeletal muscle damage. So what are the consequences of the paralysis? So which will differ from the D-tubocurarine, which is a non-depolarizing skeletal muscle relaxant. There will be first twitch which is present, which can be seen on the cheek as well as the abdomen. Paralysis will spread to the neck, limbs, face, trunk and respiratory muscle, and within 1 minute there will be a development of the apnea, and the apnea is transient and will last for only 2 to 5 minutes because of the rapid metabolism by the plasma cholinesterases. So onset and recovery will be very rapid, and sequence of paralysis is not distinguished. The onset and recovery is rapid mainly due to the rapid metabolism by the plasma cholinesterases. So what are the cardiovascular effects? So it can cause bradycardia due to the stimulation of the vagal ganglion, and also bradycardia can trigger reflex tachycardia, and that can lead to hypertension due to the stimulation of the sympathetic ganglion. And BP, there can be hypotension, and drug which can lower the BP also due to the muscarinic action. Due to the even these depolarizing succinylcholine can cause hypotension mainly due to the muscarinic action due to the vasodilation. Succinylcholine has got additional agonistic action on the nicotinic neuronal receptors, and also it can lead to histamine release, and it can cause bronchoconstriction. It can stimulate the ganglion, which can lead to hypertension. So histamine release when compared to the D-tubocurarine is much lesser with respect to the succinylcholine. So succinylcholine, coming to the pharmacokinetic parameters of succinylcholine. Succinylcholine is a quaternary ammonium group, and when it is taken orally, it is not absorbed and do not cross the blood-brain barrier or the placental barrier. So it has to be given by IV route, and it has got extremely brief duration of action, that is 5 to 10 minutes, because it is the reason being for a brief duration of action is it is rapidly hydrolyzed or metabolized by the plasma cholinesterases, which is also called as pseudocholinesterases. So the activity of the plasma pseudocholinesterases will determine or influence the duration of action of the succinylcholine. And also in some patient or some individual, there can be genetic variation or genetic variant of the plasma cholinesterase, that is they are called as atypical pseudocholinesterases. So normally the succinylcholine is metabolized by plasma or the typical pseudocholinesterases, but in genetic variant individuals there is a presence of atypical pseudocholinesterases which will not be able to metabolize the succinylcholine, and the problem arises here. So the ability to metabolize the succinylcholine can be assessed by Debicane number. So if the patient has got the atypical pseudocholinesterases, what will happen is succinylcholine will not be degraded. And what is the effect of succinylcholine on the respiratory muscles? There will be relaxation of the respiratory muscles. It can lead to apnea and also the death also. So this can be identified by knowing the concentration of the pseudocholinesterases level. So it can be done by the Debicane number, assessing the Debicane number. So what is Debicane number? Debicane number means, first let us understand, Debicane is a local anesthetic. Debicane has got ability to inhibit the normal enzyme, that means to say plasma cholinesterases will be inhibited up to 80%, and atypical plasma cholinesterases will be inhibited up to 20% normally. So the Debicane number in a normal person will be 80, and less than 80 means if the person has got the atypical pseudocholinesterases, in such individuals there will be less than 80% of the inhibition of the plasma cholinesterases will occur when you give a Debicane. So there will be proportionate concentration of increase in the atypical pseudocholinesterases. So what are the clinical uses of the succinylcholine? Clinical uses will be, it can be helpful or it can be adjuvant in terms of during the rapid endotracheal intubation is required during the electroconvulsive shock treatment to prevent the injury. Coming to the adverse effects of the succinylcholine, it can cause hyperkalemia because of the efflux of the potassium, which is responsible for again the muscle soreness. It can cause malignant hyperthermia, masseter muscle rigidity, prolonged apnea, especially in case of atypical or pseudocholinesterase genetic variant individuals, increase intragastric pressure, rise in intraocular pressure, as well as the muscle soreness. So efflux of potassium during the depolarizing blockade will increase the plasma potassium levels, and this will going to have a risk or very dangerous consequences if the patient has got burns or a spinal injury or uremia. All these individuals or the conditions will be very susceptible to hyperkalemia, and also along with that, all this condition can precipitate the arrhythmia as well due to the high potassium levels in the plasma. And next is the prolonged apnea is seen with respect to the atypical pseudocholinesterases, mainly due to the succinylcholine will not be metabolized, leading to prolonged apnea. Then there is an increased intragastric pressure and mainly due to the consequences of the fasciculations. Rise of the intraocular pressure, which is short-lived for 5 to 10 minutes, mainly due to the contraction of the myofibrils, that is extraocular muscles, and partly due to the dilation of the choroidal blood vessels. The fasciculation can cause a damage to the skeletal muscle. It can lead to breakdown of the muscle, leading to myoglobinuria after succinylcholine administration. And in case of genetically inherited conditions, there can be mutation of the voltage sensitive sodium channels, and in such individuals, the succinylcholine can complicate the endotracheal tube insertion as well as the airway management. So coming to the special points, that is the malignant hyperthermia. So why malignant hyperthermia occurs? So in case of genetically inherited individuals with the autosomal dominant trait, what happens is due to the mutation of the calcium channels, calcium release channels of the sarcoplasmic reticulum, or the mutation in the ryanodine receptors, what happens is in case of the individuals with these mutation of calcium channels, whenever you give a succinylcholine will trigger the malignant hyperthermia. So in such individuals, what will happen is there is a persistent release of the calcium, and this calcium released will going to cause persistent muscle contraction and subsequently leading to increased heat and hyperthermia. That's why the term called as malignant hyperthermia. And there is a higher susceptibility to malignant hyperthermia when it is given along with the general anesthetic agents like halothane is used along with the succinylcholine. So which will be the drug of choice for treating malignant hyperthermia? Drug of choice will be a dantrolene sodium, again a skeletal muscle relaxant. So dantrolene will going to bind to the ryanodine receptors and it will going to decrease the calcium release. A special point to be mentioned and remembered is neostigmine. Please remember it potentiate the block, phase 1 block due to the succinylcholine. Neostigmine will blocks the phase 2 block due to succinylcholine. That means neostigmine will augment the phase 1 block. Neostigmine will block or reverses the phase 2 block. Hypothermia can potentiate succinylcholine because there is a slow rate of repolarization of the muscle end plate. And the drugs like calcium channel blockers like verapamil, diltiazem can enhance the neuromuscular blockade produced by both D-tubocurarine and succinylcholine. So which are the conditions where the duration of succinylcholine will be increased, leading to the risk of apnea? Infants below 1 year, collagen diseases, thyrotoxicosis, burns, and as well as the genetic variant individuals who are having pseudocholinesterases deficiency, that is atypical pseudocholinesterases. Coming to the diagnosis, special point, whenever a neuromuscular blockade is produced by succinylcholine can lead to prolonged respiratory difficulty or respiratory problem due to the succinylcholine apnea in individuals with abnormal genetic variant of plasma cholinesterase. How to identify that? By giving a Debucane number will going to measure the ability of the patient to metabolize the succinylcholine, and it can be used to identify the risky patient. So under standard condition, Debican standardly it inhibits the normal enzymes by 80% and abnormal enzymes only by 20%. So when is it indicated? It is not indicated routinely, but may be indicated for patient with family who are having a history of plasma cholinesterase deficiency or any mutation or the genetic variant of family. Coming to the summary, we talked about the mechanism of action, which has got phase 1 as well as the phase 2 block. Phase 1 is due to the persistent depolarization and phase 2 is due to the desensitization or the downregulation of the receptors. The clinical uses, mainly it is used for endotracheal intubation. Adverse effect will be your hyperkalemia, there can be malignant hyperthermia, muscle soreness, etc. And this was the summary. Bonus concept review will be, you need to understand the differentiation of trina 4 responses with respect to the non-depolarizing blockers and the depolarizing blockers. Here, whenever the normal response is given, what happens is, whenever there is no drug or there is no presence of the succinylcholine, normally when you give a stimulus, electrical stimulus, along the ulnar nerve, there will be twitches. 4 twitches will be seen, that is T1, T2, T3 and T4. Whenever you give depolarizing blockers, what happens is that twitches with respect to the thumb, there will be twitching in the thumb due to the ulnar nerve stimulation. So whenever you give a succinylcholine, there will be a constant but diminished twitches due to the persistent depolarization. So this is the phase 1 response, whereas due to the phase 2 blockade, there is a continuous diminished response. You can see the fall of the responses with respect to the twitching. The twitching magnitude has been decreased, and this will differentiate the phase 1 and phase 2 block produced by the succinylcholine. So the answer to the questions which has been put forward in the previous slide is, so the SMR, which causes initial depolarizing followed by the NM receptor desensitization, is succinylcholine, that is depolarizing blockers. With respect to non-depolarizing blockers, we are going to antagonize the NM receptor directly. Mechanism for phase 1 block by depolarizing agent is persistent depolarization and due to the sodium channel blockade. Phase 2 blockade is due to the receptor desensitization or the downregulation of the receptors. Why depolarizing blocker action is rapid and short duration? Because rapidly metabolized by plasma cholinesterases. And which phase of depolarizing agent can be surmountable? Only the phase 2, because phase 2 can be reversed by giving neostigmine. The drug which can augment the phase 1 of the depolarizing agent is the neostigmine. So which SMR can cause malignant hyperthermia? It is the succinylcholine, which will going to cause malignant hyperthermia. And which is the drug used for the treatment of malignant hyperthermia? It is dantrolene sodium. Why succinylcholine apnea occurs? Mainly due to the individuals with atypical pseudocholinesterases. Debickin number will going to differentiate the percentage of inhibition of pseudocholinesterases and the true cholinesterases. Thereby you can identify the risky individuals who can go for the succinylcholine apnea. Thank you.